بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Our topic today will be about the subjects of the GIT surgery for the 4th stage Students College of Medicine. And today we will proceed with our topics about the liver disorders. Today we will discuss the surgical point of liver infection. The liver is affected by different microorganisms, started from viral diseases, which is a major world health problem, and it is well recognized cause for acute and chronic liver disorders. That's the viral hepatitis. Different categories of viral hepatitis: hepatitis A, hepatitis B, hepatitis C, and non-A, non-B, or D hepatitis. The most important type of viral hepatitis in regard to surgical aspect is the B hepatitis, or hepatitis B, because of its modes of transmission through blood and blood products. Another type of viral hepatitis is mainly supportive treatment with antiviral agents like interferon, ribavirin, and in cases of chronic liver disorders like liver cirrhosis due to hepatitis, here patient may require liver transplant. Another group of affection of the liver is by bacterial infection, like ascending cholangitis. Ascending bacterial infection of the liver is usually associated with obstruction of the biliary tree. Patient usually presented with jaundice, rigor, tender hepatomegaly. Diagnosis is confirmed by finding of dilated biliary ducts on ultrasound or MRCP. An obstructive picture of liver function test is present, and on blood culture, isolation of the causative microorganism can be done. Ascending cholangitis is considered as a medical emergency, since delay may result in organ failure and septicemia. Once diagnosis is established, the patient should be put on antibiotic treatment, and we are starting from second-line antibiotics like third-generation cephalosporin and rehydration. At the same time, an arrangement should be done to treat the secondary factor of biliary obstruction whether by endoscopic or percutaneous transhepatic drainage of biliary tree. Biliary stone disease is a common predisposing factor. So the causative ductal stone may be removed at time of endoscopic cholangiography, or we may do endoscopic sphincterotomy, and this with the time and medical treatment may assist in pushing the obstructing biliary stone outward. Another disorder of infection due to bacteria in the liver is pyogenic liver abscess. Most of cases, etiology of the pyogenic liver abscess may be unexplained. It has been seen in increased incidence in those patients with impaired immunity, as in elderly patients, diabetics, or immunosuppressed patients. Usually presentation of the patients is anorexia, fever, malaise accompanied by right upper quadrant discomfort. And the diagnosis may be suggested by finding of multiloculated cystic mass on ultrasound or CT scan, and this should be confirmed by aspiration of the cyst and sent for culture and sensitivity. This figure shows CT scan of a patient affected by a cystic lesion on the right lobe of the liver with characteristic appearance of fluid within the cyst and air in the upper part with air fluid interface. And this is diagnostic for pyogenic liver abscess. Most common organism causes the liver abscess are streptococci, E. coli, other enteric organisms like Streptococcus faecalis, Klebsiella, Proteus may be present in a mixed growth. Sometimes opportunistic pathogenic microorganism like Staphylococcus aureus may be seen in the culture of the aspirated fluid of the pyogenic liver abscess. How to treat a patient with pyogenic liver abscess? By antibiotic and aspiration under ultrasound guide. First line for antibiotic are penicillin combined with aminoglycoside and metronidazole, or cephalosporin and metronidazole. An important note that percutaneous drainage of pyogenic liver abscess without ultrasound guidance should be avoided, as it may result in collection of pus within the pleural cavity, which is called empyema. Another thing, a source for the liver abscess should be sought, especially in the colon. A third note, atypical clinical or radiological finding should raise the suspicion that the possibility of necrotic neoplasm. Third group of liver infection, that is the parasitic infection. Two types of infestation for the liver which are of surgical importance. First one is amoebic liver abscess. This causative microorganism is Amoeba histolytica. It is endemic in many parts in the world, and it exists in a vegetative form outside the body, spread by fecal-oral route. Most common presentation is with dysentery, which may be also present with an amoebic abscess. Classically, the patient may give a history of bloody diarrhea or dysentery about 1 to 2 weeks prior to the development of features of amoebic liver abscess. Died from the colon, then it passed through the bowel wall and reaching the liver via the portal circulation. Diagnosis of amoebic liver abscess is by isolation of the parasite from the liver lesion or from the stool and confirming its nature by microscopy. Often patients with clinical signs of amoebic liver abscess will be treated empirically with metronidazole in a dose of 750 milligrams 3 times daily for 5 to 10 days. Another important parasitic infestation of the liver is the hydatid liver disease. This is a very common condition in countries around the Mediterranean region. Our country is one of the endemic countries by this disease. Causative tapeworm is Echinococcus granulosus, which is present in the dog intestine and ova are ingested by human and passes to the portal blood to the liver. Liver abscesses are often large by time of presentation with upper abdominal discomfort or maybe presence after minor abdominal trauma as an acute abdomen due to rupture of the cyst into the peritoneal cavity. Pathology of the hydatid cysts. First thing you should know that the hydatid cyst of the liver is composed, pathologically speaking, of 3 main layers. These are the outer layer called ectocyst, which represent the response of the host tissue to the parasite. Second layer, endocyst or true cyst of the parasite, and the inner layer is a germinal layer. This figure shows the layers of the hydatid cyst. This is the outer layer, which is called the ectocyst, and it represents host response to the parasite. As to say, it is part of the host tissues. And the middle layer, which is called endocyst, which is the outer layer of the parasite. The third, or the inner small layer, which is called the germinal layer. And this layer is the only living part of the hydatid cyst. Its main function, it has two main functions. First, it produces inner cyst to the outside and secrete fluid to the inside of the cyst. And by this, increasing the amount of fluid will result in the increase of the size of the cyst progressively with the time, which later on will give signs and symptoms of the disease. Another important function of the germinal layer, it produces within the hydatid fluid, within the cyst cavity, what is called Scolicide of the hydatid cysts. These Scolicide, they represent the head segment of the adult parasite, and they have the ability to grow to the adult worm if they reach to the definitive host of the parasite, which are the ducts. These Scolicides, if you see this figure, they are attached to the germinal layer by a stalk. And with the time, due to multiple trauma to the cyst, these stalks may disintegrate and the Scolicides become free within the hydatid fluid. Usually, the hydatid fluid is clear crystalline fluid with high allergenicity. It means high allergic effect on the body. Once disintegration of the stalk is occurred, these Scolicides, which will become high in number within swimming within this fluid, they will convert the fluid from clear crystalline appearance into an opaque appearance, and these Scolicides within the fluid, they have another name, hydatid sands. If the Scolicides does not coming outside the hydatid cyst, they will become increase in size with the time, forming a small cystic lesion within the mother large cysts. These small cystic lesion, they have another name called daughter cysts. And by this, a single mother hydatid cyst will containing a lot of daughter cysts. Diagnosis of the hydatid cyst is suggested by finding of multiloculated cyst on ultrasound and is further supported by finding of floating membrane within the cyst on CT scan. Active cyst containing a large number of smaller daughter cysts, and rupture can result in implantation and growing of these new daughter cysts within the peritoneal cavity, which is result in dissemination of the disease within the body. Liver cyst can also rupture through the diaphragm, producing empyema of pleural cavity, or it get rupture into biliary tract, might resulted in obstructive jaundice. In summarization, clinical presentation of the hydatid cyst of the liver. Patient could be asymptomatic, discovered accidentally on investigation for other disorder. Second presentation, the patient may come with abdominal pain. Third presentation, patient may be presented with abdominal mass, especially on the right side of the abdomen. Some patient may presented with the complication of the hydatid cyst, like obstructive symptoms, obstructive jaundice, or abdominal abscess. Clinical and radiological diagnosis can be supported by serology for antibody to hydatid antigen in the form of ELISA test. Is indicated to prevent progressive enlargement and rupture of the cyst. If the cyst is small in size, a trial of a course of albendazole or mebendazole may be tried. Failure to respond to medical treatment usually requires surgical intervention. What are the complications of the hydatid cyst? First complication is calcification of hydatid cyst. Calcified hydatid cyst is dead cyst, require no treatment. Another complication is infection, and this will convert the hydatid cyst into pyogenic liver abscess. A third complication is rupture of the hydatid cyst, and rupture could occur into the peritoneal cavity. Since its content is highly allergenic, so the patient presented with anaphylactic shock. Another route for rupture is biliary rupture with resultant obstructive jaundice, or rupture may pass into the pleural cavity, causing pleural effusion. A fourth complication of the hydatid cyst is by a size of the cyst, which will result in obstruction, and the patient may be presented with obstruction to the biliary tree in the form of obstructive jaundice. Surgical option for management of the hydatid cyst is ranging from resection of the part of the liver resection, or local excision of the cyst, or the most common method, which is the de-roofing of the hydatid cyst of the liver with evacuation of the content. The most important challenging point in the surgical management of the hydatid cyst is contamination of the peritoneal cavity with the cyst content, which may be result in the seedling of the hydatid cyst within the peritoneal cavity at time of surgery with the active hydatid daughter cyst, and this should be avoided all the time by continuing drug therapy of the patient with albendazole, and this should be combined with extra measure taken during surgery by packing of the peritoneal cavity with saline soaked or hypertonic saline soaked pack of the peritoneal cavity to prevent dissemination and seedling of the content of the hydatid cyst into the peritoneal cavity before we are doing opening or managing of the hydatid cyst. During surgery, annotation should be done for biliary communication. This size of communication of biliary tree with the hydatid cyst cavity should be closed by suturing. The residual cavity of the hydatid cyst may become infected, and this complication may be reduced by packing of the space with a pedicle greater omentum, which is called omentoplasty. Rupture of the hydatid cyst into biliary tree may result in obstructive jaundice or acute cholangitis. This complication should be treated by endoscopic clearance of the daughter cyst prior to the cyst removal. One of the most challenging point in treatment of the hydatid cyst is the seedling of the hydatid content within the peritoneal cavity and the body, which result in recurrence of the disease after surgical treatment. And to prevent this complication, Scolicide are used, which are chemical substances used to kill the infective part of the parasite. Long list of Scolicide have been tried, like hypertonic saline, chlorhexidine, povidone iodine. The most important complication for using of the Scolicide in surgery of the hydatid cyst, it is the sclerosing cholangitis, which have been seen to occur commonly if the formalin used as a Scolicide. Nowadays, formalin have been obsolete to be used as a Scolicide in treatment of hydatid cysts. After removal of the hydatid cyst, another important point is what to do with the residual cavity of the hydatid cyst within the liver. There are different methods, surgical methods, which have been used to manage this cavity. First, by either putting extra cystic drain or de-roofing of the cavity or marsupilization or saucerization, or what is commonly used is the